dash 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 colon underscore 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 b underscore underscore. ORI Bankart anterior glenoid rim, anterior underscore or dislocatio underscore. Section 1. Vocab. Stress fracture is abnormal stress on normal bone. Insufficient fracture is normal stress on abnormal bone. Fracture healing. In general, bones heal in about 6 to 8 weeks, but is bone location dependent. Healing is the fastest in the phalanges, around 3 weeks, and the slowest in the tibia, around 2 to 3 months. Phalanges equals heal fast, 3 weeks, tibia equals heal slow, 10 weeks, everything else equals 6 to 8 weeks. Consider repeat in 7 to 10 days, a disclaimer cowardly radiologists throw out when they are afraid they missed a fracture. I bring this up because there is an actual physiologic reason why this is helpful. This time interval, 7 to 10 days, is when granulation tissue is forming between the fragments leading to a vascularization of the hematoma. The appearance of this on a radiograph is increased lucency, which means the fracture is easier to see. So when they come back in 7 to 10 days, you should be able to see the fracture line, if one is present. More vocab. Delayed union equals fracture not healed within the expected time period, but still might. Some sources will say twice as long as expected. Non-union equals fracture is not going to heal without intervention. Some sources will say 6 to 9 months. The classic locations are the scaphoid, anterior tibia, and lateral femoral neck. Malunion equals this is union in poor anatomic position. Risk factors, there are lots, but these are the ones I think are most testable. Vitamin D deficiency is associated with non-union. Gastric bypass patients have altered calcium absorption, causes secondary hyperparathyroid and stripping of calcium from bones, and therefore higher rates of non-uron. 12. Hand-eye wrist. Scaphoid fracture, most common carpal bone fracture 70% at the waist. Adults, blood supply is distal to proximal, with the proximal pole most susceptible to AVN. The first sign of AN equals scoliosis, the dead bone can't turn over. I recycle, CI, if I fractures are most susceptible to JJ, G and non-union axial CQN fractions occur AOL AVN on MRI. This is tricky stuff with lots of papers contradicting each other. Probably the most reliable is sign is dark on TL. Blood supply distal to proximal, the proximal pole will AVN. Scapholunate ligament tear, the Terry Thomas look gap between the scaphoid and lunate on plain film. There are actually 3 parts, volar, dorsal, and middle, with the dorsal band being the most important for carpal stability, opposite of lunotriquetra, which is volar. Disruption of the ligament predisposes for DISI deformity, page 15. SLAC and SNAC wrists. Both are potential complications of trauma, with similar mechanisms. SLAC wrist, scaphoid lunate advanced collapse, occurs with injury or degeneration via CPPD to the SL ligament. SNAC wrist, scaphoid non-union advanced collapse, occurs with a scaphoid fracture. Just remember that the scaphoid always wants to rotate in flexion. The scaphoid lunate ligament is the only thing holding it back. If this ligament breaks, it will tilt into flexion, messing up the dynamics of the wrist. The radial scaphoid space will narrow, and the capitate will migrate proximally. Treatment depends on the occupation/needs of the wrist. Wrist fusion will maximize strength but cause a loss of motion. Proximal row carpectomy will maximize ROM but cause a loss of strength. SNAC. SLAC. The things to know are: radioscaphoid joint is first to develop degenerative changes. Capitate will migrate proximally, and there will eventually be a DISI deformity. 13. Carpal dislocations, a spectrum of severity. Least severe. Lunate II. V01 II. Scapholunate dissociation, perilunate dislocation. SL, wider than 3 mm clenched fist view can worsen it, would make a good next step. Question, chronic SL. Trivia to know equals 60% associated with scaphoid fractures. Dissociation can result. Note that the in a slag wrist lunate stays put, the capitate and radius move back. Comma _/greater arc // / L space of Poirier lesser arc. I. M. I. 14. DISI vs VISI DSL ligament. This is a very confusing topic, thus high yield. If you scaphoid have carpal ligament disruption, the carpal bones will rotate the way they naturally want to. The reasons for their rotational desires are complex, but basic 11y have to do with the shape of the fossa they sit on. Just remember the scaphoid wants to flex, rock volar, and the lunate wants to extend, rock dorsal. The only thing holding them back is their ligarnentous attachment to each other. DISI, dorsal intercalated segmental instability. I'll like to call this dorsiflexion instability because it helps me remember what's going on. After a W-ided injury scapholunate side, the lunate becomes free of the stabilizing force of the scaphoid and rocks dorsally. Ember SL ligament injury is common, so this is common. VISI, volar intercalated segmental instability. I like to call this vol.ar. FL_il, palm. Palmar flexion, instability because it helps me remember what's going on. After a .ijjp.ar sided injury, lunotrial side, the lunate no longer has the stabilizing force of the lunotriquetral ligament and gets ripped volar with the scaphoid. Remember the scaphoid stays up late every night dreaming of tilting volar. Remember TIM injury is not common, so this is not common. It's so uncommon in fact that if you see it, it's probably a normal variant due to wrist laxity. N equals CLO. / comma. Dorsal volar / I, comma, / ______, comma, /. Normal scaphoid lunate angle is 30 to 60 degrees. DISI, widening of the SL angle, with dorsiflexion of the lunate. Angle 60, some sources say 80. S. ____. Visi, narrowing of the SL angle, with volar flexion of the lunate and scaphoid. Angle 30, this acute angle looks like AV to me V4V. /66L.C. Low circ. Ember SL ligament injury is common, so this is common. Visi, volar intercalated segmental instability. I like to call this vol.ar. FL_il, palmar flexion. Bennett and Rolando fractures. They are both fractures at the base of the first metacarpal. The Rolando fracture is comminuted, Bennett is not. Trivia: the pull of the abductor pollicis longus, the APL, tendon is what causes the dorsolateral dislocation in the Bennett fracture. Attachment of the APL. Bennett FX. Game key ERs TB, Y_MB. Rolando FX, PMM, 1.A/T.DL. Sulcian.icock tunra, at KSN of TH. Ox IMIJ hour, associated with ulnar collateral ligament disruption. The frequently tested association is that of a Stena lesion. A Stoyer lesion is when the adductor tendon gets caught in the torn edges of the UCL. The displaced ligament won't heal right, and will need surgery. It makes a XOYQ appearance on MRI supposedly. Next step: don't do stress views that can cause a Stena. MRI is the more appropriate test. Carpal tunnel syndrome, CTS, median, and Euro, Listribue_TI at WNB radial as ECT of fourth diet, often bilateral, and may have thenar muscle atrophy. On ultrasound, enlargement of the nerve is the main thing to look for. It's usually from re-edif e-tra. Trivia equals association with .dia, is pregnancy, and thyroidism. Guyon's canal syndrome, entrapment of the ulnar nerve as it passes through Guyon's canal, formed by the pisiform, and the harnett, and the crap that connects them. Classically caused by handlebar palsy. Fracture of the hook of the hamate can also eat on that ulnar nerve. 16. Distal radius I-wrist fractures. There are 3 named fractures of the distal radius I-wrist worth knowing. Distal radius. G. /. =====. Volar dorsal. Cole's fracture, outward, collie dogs like it outside. Distal metaphysis FX dorsal angulation old lady fracture ulnar styloid FX is commonly associated. Volar dorsal. Smith fracture, inward. Distal metaphysis FX volar angulation younger patient ulnar styloid FX is commonly associated. Radial tilt. There is a normal volar tilt of around 11 degrees with distal radial fractures. This can get fucked up. Most orthopods won't accept anything past neutral. A true lateral is necessary to measure it. How do you know your lateral is true? The volar cortex of the pisiform overlies the central 113 of the interval between the scaphoid and capitate. Radial rim. Baftal, FFR dorsal or volar. Radial rim FX volar is more common. Radial carpal dislocation is the hallmark, typically surgical. They have a high rate of redislocation I-mat union. Volar dorsal. 17. Ulnar variance I-impaction. Ulnar variance, this is determined by comparing the lengths of the ulna and distal radius. These length differences can occur congenitally, or be acquired from impaction I-fracture deformity. Neutral positive. Testable association ulnar impaction syndrome. Ulnar impaction syndrome, Ulnar abutment. Seen with positive ulnar variants. Essentially the distal ulna smashes into the lunate, degenerating it cystic change I geodes etc., and tears up the TFCC, triangular fibro-cartilage complex. Negi/RZE. Testable association AVN of the lunate Kienbeck. TFCC anatomic trivia. The TFCC is a super complicated piece of anatomy. Asking anatomy questions about this structure is well beyond the scope of the exam, one would assume. Having said that, there are two anatomic trivia points that could be potentially asked. 1. Which tendon is associated with THG, FCC? Extensor carpi ulnaris, compartment 6. 2. Injury where in the TFC ISR star, pound 911 I bad. Just like the meniscus in the knee, the TFC has a peripheral, ulnar-sided, red zone, which has a good blood supply and can heal, and central white zone that doesn't do as well. So peripheral good. 18. Elbow I forearm. General trivia. Radial head fracture is most common in adults, is most common in peds. Sale sign, elevation of the fat pads from a joint EFFUS10N. Supposed a sign of occult fracture. The testable trivia is, 1. The posterior fat pad is more specific, posterior is positive, and 2. The posterior fat pad can appear falsely elevated, false positive, if the lateral isn't a true 90-degree flex lateral. Posterior positive, posterior position dependent capitellune fractures are associated with posterior dislocation. K._._. Forearm fractures I eponyms. Forearm fractures are ring or pretzel-type fractures similar to the pelvis or mandible. Think about breaking a pretzel, it always snaps in two spots, not just one. So forearm fractures are often two fractures, or a fracture and dislocation. There are three French-sounding, therefore high-yield, fractures of the forearm which follow this ring-I pretzel principle. 0A/J /O. Monteggia fracture, MUGR. Fracture of the proximal ulna, with anterior dislocation of the radial head. Dislocation of the radial head follows the angulation of the ulnar FX. Galeazzi fracture, MUGR. Radial shaft fracture, with anterior dislocation of the ulna at the DRUJ. Essex-Low-Presti. Fracture of the radial head and anterior dislocation of the distal radial ulnar joint. Unstable fracture, with rupture of the interosseous membrane. 0. 19. The dreaded PEDS elbow covered in the PEDS chapter, see Chapter 2, Volume 1. Cubital tunnel syndrome. There are several causes, the most common in the real world is probably repetitive valgus stress. The most common shown on multiple choice is probably an accessory anconuse. WTF is an anconuse? It a piece of shit muscle that does nothing but get in the way of an orthopedic scope. It's normally on the lateral side the elbow. You can have an accessory anconuse, also called an anconuse epitrochlearis, on the medial side which will exert mass effect on the ulnar nerve. Anatomic trivia. The site where the ulnar nerve passes beneath the cubital tunnel retinaculum, also known as the epicondyloolecranon ligament or Osborne's ligament. \V 0 0 ORMLF _. Cubital tunnel syndrome, secondary to an accessory anconuse. Austere band of the UCL accessory anconuse, aka anconuse epitrochlearis. 20. Shoulder, MRI covered separately. Dislocation, anterior-inferior, subcoracoid, are by far the most common, like 90%. O'Hill-Sachs is on the humerus. O'Hill-Sachs is on the posterior lateral humerus, and best seen on internal rotation view. O-Bankart, anterior-inferior labrum. O greater tuberosity avulsion fracture occurs in 10 to 15% of anterior dislocations in patients over 40. Posterior dislocation, uncommon, probably from seizure or electrocution. O rim sign, no overlap. Glenoid and humeral head. O trough sign, reverse Hill Sachs, impaction on anterior humerus. O arm may be locked in internal rotation on all views. Inferior dislocation, luxatio erecta humeri. This is an uncommon form, where the arm is sticking straight over the head. The thing to know is 60% get neurologic injury, usually the axillary nerve. Hill Sachs lateral humeral head impaction fracture, anterior. J. Dislocation. F dash 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 colon underscore 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 B underscore underscore. ORI Bankart anterior glenoid rim, anterior underscore or dislocatio underscore underscore N underscore underscore J. I trough sign, INEI or humeral head Imschen fracture, posterior dislocation. II reverse bank, RTFJ, austere glenoid rim, posterior dislocatio, dash a dash a dash a dash dash a dash a dash a dash a dash dash a dash a dash dash a dash dash. Memory tool, work S for me anyway. I remember that hip dislocations are posterior, from the straight leg dashboard mechanism. Then I just remember that shoulders are the opposite of that. The other one. Is the other one. Shoulder equals usually anterior backslash P, comma. S plus. Internal rotation, normal. Ernal rotation, high/I Sachs. 21. Proximal humerus fracture, this is usually in an old lady falling on an outstretched arm. Orthopods use the near classifications, how many parts the humerus is in. 3 or 4 part fractures tend to do worse. The post-op shoulder prosthesis. There are 4 main types: humeral head resurfacing, hemiarthroplasty, total shoulder arthroplasty, and the reverse total shoulder arthroplasty. Who gets what? The surgical choice depends on 2 main factors: 1 is the cuff intact, and 2 is the glenoid trashed. Here is the breakdown. Glenoid intact. Complications. Trivia. Cuff intact. Resurfacing or hemi. TSA. Cuff deficient. Hemi or reverse. Reverse. Total shoulder. Most common complication equals loosening of the glenoid component. Total shoulder complication, anterior escape. This describes anterior migration of the humeral head after subscapularis failure. Reverse total shoulder does not require an intact rotator cuff. Patient rely heavily on the deltoid. Reverse shoulder complication, posterior acromion fracture, from excessive deltoid tugging. 22. Hip/femur. Femoral neck fractures on the inside, medial, is the classic stress fracture location. On the outside, lateral, is the classic bisphosphonate-related FX location. Bisphosphonate fracture, lateral femur, stress would be medial. Hip fracture. I dislocation, you see these with dashboard injuries. The posterior dislocation, almost always associated with a fracture as it's driven backwards, is much more common than the anterior dislocation. Exam buzzword is foot in internal rotation. Anterior column vs posterior column. The acetabulum is supported by 2 columns of bone that merge together to form an inverted Y. Liopectineal line equals anterior. Ilioischial line equals posterior. Remember, you sit on your ischium. The both column fracture by definition divides the ilium proximal to the hip joint, so you have no articular surface of the hip attached to the axial skeleton. That's a problem. Backslash. Liopectineal. Corona mortis, the anastomosis of the inferior epigastric and obturator vessels, sometimes rides on the superior pubic ramus. During a lateral dissection, sometimes used to repair a hip fracture, this can be injured. I talk about this more in the vascular chapter. Hip fracture leading to AVN. The location of the fracture may predispose Predisposed to AVN. It's important to remember that since the femoral head gets vascular flow from the circumflex femorals, a displaced intracapsular fracture could disrupt this blood supply, leading to AVN. Testable point: degree of fracture displacement corresponds with risk of AVN. 23. Avulsion injury. This is seen more in kids than adults. Adult bones are stronger than their tendons. In kids it's the other way around. One pearl is that if you see an isolated avulsion of the lesser trochanter in a seemingly mild trauma eye injury in an adult, query a pathologic fracture. Now, to discuss what I believe is the highest yield topic in MSK for the core: where did the avulsion come from? The easiest way to show this is a plain film pelvis, or MRI, with a tug/avulsion injury to one of the muscular attachment sites. The question will most likely be what attaches there, or which muscle got avulsed. Symphysis adductor group. I. Ischial tuberosity hamstrings. S. iliac crest. Crest. Abdominal muscles. AS.IS/J-S.arterius. Alls. Rectus femoris. Greater trochanter gluteal muscles. Lesser trochanter liopsos. 24. Snapping hip syndrome, the clinical sensation of snapping or clicking with hip flexion and extension. The key point is that it is clinical. This is the way people work this thing up. Clinical eval for the external type, IT band snapping over the greater trochanter. If clinically rule out, next step equals X-ray. This is to evaluate for the intra-articular type, looking for hip Deegan, eye loose bodies, etc. If no Deegan, next step equals ultrasound. This is to look for the internal type, look for dynamic snapping of the iliopsoas over the iliopectineal eminence or femoral head asterisk. This has to be shown with a cine, because the finding is a dynamic moving of a tendon. If you see a hip ultrasound for snapping, this is what they are going /or. If US negative, next step equals MRI arthrogram. This is to evaluate for the intra-articular type. Again, this time looking for labral tears. What you need to know for multiple choice, snapping hip, is a clinical sensation. They have to tell you that patient feels snapping, the 3 types, and the workup algorithm above, types, external, most common, equals iliotibial band over greater trochanter internal equals iliopsoas over iliopectineal eminence or femoral head intra-articular equals labral tears, I joint bodies hip labrum tears pearl #1 equals are like 95% anterior superior. If you show you a hip MR, and want to know where the labrum is torn, just pick anterior superior. It's almost always there. Hip labrum tears pearl #2 equals if they show you a paralabral cyst, that is a hint that the labrum is tom, same with a meniscal cyst in the knee, or a labral cyst in the shoulder. 25. Femoroastibular impingement, FAI. This is a syndrome of painful hip movement. It's based on hip bifemoral deformities, and honestly might be total BS. Supposedly it can lead to early degenerative changes. There are 2 described subtypes, A, cam, and B, pincher. Technically there is a mixed type, but I anticipate multiple choice to make it more black or white. Cam type, this is an osseous bump along the femoral head neck junction. Normal cam type. Pincer TEV, whereas the cam type is a deformity of the femur, the pincer type represents a deformity of the acetabulum. Whereas the cam type is more common in a young athletic male, the pincer is more common in a middle-aged woman. Insert sexist joke here. The most classic way to show or ask this is the so-called crossover sign, where the acetabulum is malformed, causing the posterior lip to cross over the anterior lip. A key point is that the coccyx needs to be centered at the memory aid. I remember that the femoral 1, cam type, is more common in men because the femoral head kinda looks like a penis. Be honest, you were thinking that too. Symphysis pubis. To even evaluate this, rotation fucks things up. The other associated finding, S, of the pincer subtype worth knowing are the acetabular overcoverage buzzwords coxa profunda and protrusio, and the ischial spine sign. Normal coxa profunda, acetabulum projects medial to the ilioischial line. Acetabular protrusion, femur projects medial to the ilioischial line. Prominent ischial spine. 26. L. Sacrum. You can get fractures of the sacrum in the setting of trauma, but if you get shown or asked anything about the sacrum, it's going to be either A. SI degenerative change, discussed later, B. Unilateral SJ infection, C. Echadoma, discussed later, D. Sacral agenesis, or E. An insufficiency fracture. Out of these 5 things, the insufficiency fracture is probably the most likely. Sacral insufficiency fracture, the most common cause is postmenopausal osteoporosis. You can also see this in patients with renal failure, patients with RA, pelvic radiation, mechanical changes after hip arthroplasty, or extended steroid use. They are often, usually, occult on plain films. They will have to show this either with a bone scan or MRJ. The classic Honda sign, from the H-shaped appearance, is probably the most likely presentation on a multiple-choice test. Knee I tibia I fibula. Segond fracture, this is a fracture of the lateral tibial plateau, common distractor is medial tibia. The thing to know is that it is associated with ACL tear, 75%, and occurs with internal rotation. Reverse Segond fracture, TH.IS, is a fracture of the medial tibial lateau. The thing to know is that it is associated with a PCL tear, and occurs with external rotation. There is also an associated medial meniscus injury. Reverse Segond FX Meckel, Lee /ICJYTU. At PL/hour. Honda sign, sacral insufficiency FX. /.add RJ. Segond FX CLL, FACL F/O.I__. Arcuate sign, this is an avulsion of proximal fibula, insertion of arcuate gamut comp X. The thing to know is that 90% are associated with cruciate ligament injury, usually. --1, CJ. 27. Deep intercondylar notch sign. This is a depression of the lateral femoral condyle, terminal sulcus, that occurs secondary to an impaction injury. This is associated with ACL tears. Patella dislocation, basically always lateral, and the medial patellofemoral ligament is injured. There is a characteristic appearance on MRI, which will be shown and discussed later in this chapter. Patella alti baja. The patella will move up or down in certain traumatic situations. If the quadricep tendon tears, you will get unopposed pull from the patellar tendon resulting in a low patella baja. If the patella tendon tears, you will get unopposed quadriceps tendon pull resulting in a high patella alta. The classic association with patellar tendon tear, alta, is SLE, also can see in elderly, trauma, athletics, or RA. Bilateral patellar rupture is a buzzword for chronic steroids. Patella alta. Patella baja. Tibial plateau fracture. This injury most commonly occurs from axial loading, falling, and landing on a straight leg. The lateral plateau is way more common than the medial. If you see medial, it's usually with lateral. Some dude named Schitzker managed to get the classification system named after him, of which type 2 is the most common, split, and depressed lateral plateau. Pylon fracture, tibial plafond fracture. This injury also most commonly occurs from axial loading, with the talus being driven into the tibial plafond. The fracture is characterized by comminution and articular impaction. About 75% of the time, you are going to have fracture of the distal fibula. Tibial shaft fracture. This is the most common long bone fracture. It was also listed as the most highly tested subject in orthopedic OIT exam, with regard to trauma, over the last 8 years. Apparently there are a bunch of ways to put a nail or plate in it. It doesn't seem like it could be that high yield for the core compared to other fractures with French or Latin sounding names. I will point out that the tibia is one of the slowest healing bones in the body. 28. TO fractures. This is Salter-Harris 3, through the anterolateral aspect of the distal tibial epiphysis. Triplane fracture. This is a Salter-Harris 4, with a vertical component through the epiphysis, horizontal component through the physis, and oblique through the metaphysis. Maison of fracture. This is an unstable fracture involving the medial tibial malleolus and slash or disruption of the distal tibiofibular syndesmosis. The most common way to show this is to first show you the ankle with the widened mortise, and next step, get you to ask for the proximal fibula, which will show the fracture of the proximal fibular shaft. This fracture pattern is unique as the forces begin distally in the tibiotalar joint and rides up the syndesmosis to the proximal fibula. For some reason, knowing that the fracture does not extend into the hind foot is a piece of valuable trivia. 29. Foot eye ankle. Casanova fracture. If you see bilateral calcaneal fractures, you should next step, look at the spine for a compression or burst fracture. These tend to occur in axial loading patterns, possibly from jumping out a window to avoid an angry husband. Trivia. Caroneal tendons can become entrapped with lateral calcaneal fractures. Baller S angle, the line drawn between the anterior and posterior borders of the calcaneus on a lateral view. An angle less than 20 is concerning for a fracture. Jones fracture. This is a fracture at the base of the fifth metatarsal, L.5 cm distal to the tuberosity. These are placed in a non-weight bearing cast, may require internal fixation, because of risk of non-Uman. Avulsion fracture of the fifth metatarsal. This is more common than a Jones fracture. The classic history is a dancer. It may be secondary to tug from the lateral cord of the plantar aponeurosis, or peroneus brevis. This is controversial. Stress fracture of the fifth metatarsal. This is considered a high-risk fracture, hard to heal. Normal baller's angle. Stress FX. Avulsion FX. OS peroneum, within peroneus jongus. Flattened calcaneus equals narrow angle. 30. Lees-Frun injury. This is the most common dislocation of the foot. The Lees-Frun joint is the articulation of the tarsals and metatarsal heads. This joint would make a good place to amputate, if you were a surgeon assisting in the Napoleonic invasion of Russia. The Lees-Frun ligament connects the medial cuneiform to the second metatarsal base on the plantar aspect. If the ligament goes out, you can see two patterns. 1. Homolateral, everyone moves lateral. 2. Divergent, the IST-MT goes medial, the second to fifth MT goes lateral. Mechanism. Extreme plantar flexion and axial load. What you need to know, can't exclude it on a non-weight bearing film. Associated fractures are most common at the base of the second MT, flex sign, fracture non-union, and post-traumatic arthritis are gonna occur if you miss it plus a lawsuit. Flex sign. This is a small bony fragment in the Lees-Frun space between first MT and second MT that is associated with an avulsion of the LF ligament. Spine. Fractures and other acquired pathologies of the spine are discussed in detail in the spine section of the neuro chapter. 31. Stress eye insufficiency fractures. Stress fracture vs insufficiency fracture. A stress fracture is the result of abnormal stress on normal bone. An insufficiency fracture is the result of normal stress on abnormal bone. Compressive side vs tensile side. This comes up in two main areas, the femoral neck and the tibia. Fractures of the compressive side are constantly getting pushed back together. These do well. Fractures of the tensile side are constantly getting pulled apart. These are a pain in the ass to heal. Femoral stress fracture. Fractures along the compressive, medial, side are more common, typically seen in a younger person along the inferior femoral neck. Fractures along the tensile, lateral, side are more common in old people. Compressive vs tensile forces, femoral neck and tibia. Tibial stress fracture. This is the most common site of a stress fracture in young athletes. These are most common on the compressive side, posterior medial, in either the proximal or distal third. Less common are the tensile side, anterior, fractures, and these favor the mid-shaft. They are bad news and don't heal, often called dreaded black lines. SONK, spontaneous osteonecrosis of the knee. This is totally named wrong, as it is another type of insufficiency fracture. You see this in old ladies with the classic history of sudden pain after rising from a seated position. Young people can get it too, much less common, usually seen after a meniscal surgery. Things to know about SONK. It's an insufficiency fracture, not osteonecrosis. Think sync, not SONK favors the medial femoral condyle, area of maximum weight bearing, usually unilateral in an old lady without history of trauma associated with meniscal injury. SONK, diffuse increased signal, edema. Navicular stress fracture. You see these in runners who run on hard surfaces. The thing to know is that just like in the wrist, the navicular is high risk for AVN. 32. March fracture. This is a metatarsal stress fracture, which is fairly common. Classically seen in military recruits that are marching all day long. Calcaneal stress fracture. The calcaneus is actually the most fractured tarsal bone. The fractures are usually intra-articular, 75%. The stress fracture will be seen with the fracture line perpendicular to the trabecular lines. You'll rue the day you crossed me trabecular lines. Typical calcaneal trabecular lines. I'll take the penis mightier for $600. Orientation of calcankle, stress FXPP / and O. OO //. High risk vs low risk stress fractures. You can sort these based on the likelihood of uncomplicated healing when treated conservatively. High risk femoral neck, tensile side, transverse patellar fracture, anterior tibial fracture, mids haft, 5th metatarsal talus tarsal navicular sesamoid great toe. Low risk femoral neck, compressive side, I longitudinal patellar fracture posterior medial tibial fracture 2 and 1 and 3rd metatarsal calcaneus. 33. Section 2. Osteoporosis, osteopenia, and a VN. VN. Osteopenia, this just means increased lucency of bones. Although this is most commonly caused by osteoporosis, that is not always the case. Osteomalacia, this is a soft bone from excessive uncalcified osteoid. This is typically related to vitamin D issues, either renal causes, liver causes, or other miscellaneous causes. It generally looks just like diffuse osteopenia. For the purpose of multiple choice, you should think about 4 things: ill-defined trabeculae, ill-defined corticomedullary junction, bowing, and looser zones. Looser zone, these things are wide lucent bands that transverse bone at right angles to the cortex. These things can happen in lots of different locations, but the classic 2 are the femoral neck and the pubic rami. Typically there is sclerosis surrounding the lucency. Why you should think 2 things, osteomalacia and rickets. Less common is 0-1. The other piece of trivia is to understand they are a type of insufficiency fracture. Looser zones, raise your suspicion for this shit when you see 1. Symmetric findings, 2. The 90-degree to the cortex line. Osteoporosis, the idea is that you have low bone density. Bone density peaks around 30 and then decreases. It decreases faster in women during menopause. The imaging findings are a thin sharp cortex, prominent trabecular bars, lucent metaphyseal bands, and spotty jucencies. Causes, age is the big one. Medications, steroids, heparin, dilantin, endocrine issues, Cushing's, hyperthyroidism, anorexia, and osteogenesis imperfecta. Complications, fractures, most commonly of the spine, 2° D most common is the hip, JRD most common is the wrist. // I. 7/L/J / 34. DEXA, this is a bone mineral density test, and an excellent source of multiple choice trivia. General things to know about DEXA T-score equals density relative to young adult T-score defines osteopenia vs osteoporosis T-score, 1.0 equals normal, -1.0 to -2.5 equals osteopenia, -2.5 osteoporosis Z-score equals density relative to age match control, to ZA exam age, false negative I positives, see below. False positive I negative on DEXA, DEXA works by measuring the density. Anything that makes that higher or lower than normal can fool the macron. False positive, absent normal structures, status post-laminectomy. False negative, n equals --::::s. Including excessive os.q-piates, derma, 9-1-I cations, or 1-1 including too much of the femoral shaft when doing a hip, can elevate the number as the shaft normally has denser bone. Compression Fx in the area measured. R. Degree RC. Reflex sympathetic dystrophy, RSDT. SC, O.V /. Also called complex regional pain syndrome, which makes it sound like some rheumatology psychosomatic bullshit, i.e. fibromyalgia. Also called Sedec atrophy, which makes it sound serious, like some incurable neurodegenerative death sentence. The classic clinical vignette is a history of trauma or infection. On plain film, it can cause severe osteopenia, like disuse Section 2. Osteoporosis, osteopenia, and AVN. Osteopenia, this just means increased lucency of bones. Although this is most commonly caused by osteoporosis, that is not always the case. Osteomalacia, this is a soft bone from excessive uncalcified osteoid. This is typically related to vitamin D issues, either renal causes, liver causes, or other miscellaneous causes. It generally looks just like diffuse osteopenia. For the purpose of multiple choice, you should think about 4 things: ill-defined trabeculae, ill-defined corticomedullary junction, bowing, and Looser zones. Looser zone, these things are wide lucent bands that transverse bone at right angles to the cortex. These things can happen in lots of different locations, but the classic 2 are the femoral neck and the pubic rami. Typically there is sclerosis surrounding the lucency. Why you should think 2 things, osteomalacia and rickets. Less common is 0-1. The other piece of trivia is to understand they are a type of insufficiency fracture. \. Looser zones, raise your suspicion for this shit when you see 1. Symmetric findings, 2. The 90° to the cortex line. Osteoporosis, the idea is that you have low bone density. Bone density. Bone density peaks around 30 and then decreases. Decreases. It decreases faster in women during menopause. The imaging findings are a thin sharp cortex, prominent trabecular bars, lucent metaphyseal bands, and spotty jucencies. Causes, age is the big one. Medications, steroids, heparin, dilantin, endocrine issues, Cushing's, hyperthyroidism, and anorexia, and osteogenesis imperfecta. Complications, fractures, most commonly of the spine, 2 degree D most common is the hip, JRD most common is the wrist. /I. 7/L/J. Osteoporosis, the DEXA, this is a bone mineral density test, and an excellent source of multiple choice trivia. General things to know about DEXA T-score equals density relative to young adult T-score defines Osteopenia vs osteoporosis T-score, 1.0 equals normal, -1.0 to -2.5 equals osteopenia, -2.5 osteoporosis Z-score equals density relative to age match control, to ZASM age false negative I positives see below. False positive I negative on DEXA. DEXA works by measuring the density. Anything that makes that higher or lower than normal can fool the macron. False positive, absent normal structures, status post-laminectomy. False negative, n equals dash backslash dash dot colon dot p comma dot backslash dot s. Including excessive os dot qpiates, derma, 9 sif underscore I cations, or 1 including too much of the femoral shaft when doing a hip, can elevate the number as the shaft normally has denser bone. Underscore. Compression Fx in the area measured. R. Degree RC. Reflex sympathetic dystrophy, RSDT. SC, O.V backslash. Also called complex regional pain syndrome, which makes it sound like some rheumatology psychosomatic bullshit, i.e. fibromyalgia. Also called SIDEC atrophy, which makes it sound serious, like some incurable neurodegenerative death sentence. The classic clinical vignette is a history of trauma or infection. On plain film, it can cause severe osteopenia, like disuse osteopenia. Some people say it looks like unilateral RA, with preserved joint spaces. Hand and shoulder are most common sites of involvement. It's one of the many causes of a 3-phase hot bone scan. In fact, intraarticular uptake of tracer on bone scan is typically seen, on multiple choice, in patients with RSD, secondary to the increased vascularity of the synovial membrane, and this is somewhat characteristic. 35. Transient osteoporosis. There are two types of presentations. Transient osteoporosis of the hip. For the purpose of multiple choice tests, by far you should expect to see the female in the JN1 trimester of pregnancy with involvement of the left hip. Having said that, it's actually more common in men in whom it's usually bilateral. The joint space should remain normal. It's self-limiting, hence the word transient, and resolves in a few months. Plain film shows osteopenia, MRI shows edema, bone scan shows increased uptake focally. Regional migratory osteoporosis. This is an idiopathic disorder which has a very classic history of pain in a joint, which gets better then shows up in another joint. It's associated with osteoporosis, which is also self-limiting. It's more common in men. Hip edema, strategy session, this vs that transient osteoporosis vs AVN vs FX. On radiograph, transient osteoporosis and a VN look totally different. Transient osteoporosis is superlucent, so lucent that sometimes you can barely see the femoral head. A VN on the other hand, will have patchy areas of sclerosis. FO. Normal transc 1 and AVN osteoporosis. On MRI, the story is different. These things can look similar. They both have edema on STIR, and they both are dark on TL. The difference is that a VN should be shown with a serpiginous dark line, double line if you are lucky.